Hello everyone, welcome to today's lecture. Today we are going to discuss about hypokalemia. We will discuss regarding recognition of hypokalemia, evaluation of hypokalemia and management of low serum potassium level. It is the most common electrolyte disturbance encountered in clinical practice, so it is very important for every doctor and nurses to know hypokalemia. Let's first start with definition. Hypokalemia is defined as serum potassium concentration of less than 3.5 milliequivalent per liter, either due to deficit in total body potassium or abnormal shift of total potassium into the cells. It is further classified as mild, moderate, and severe. Mild hypokalemia is potassium level 3 to 3.4. Moderate is 2.5 to 2.9 and severe is less than 2.5. Discussing about mechanism of hypokalemia, low serum potassium rises either due to total deficit of the true deficit of the potassium and or from the shift of potassium across cell membrane inside the cell itself, leading to final deficit in the extracellular space. So true deficit of potassium occurs either due to gastrointestinal loss, which is either by vomiting or diarrhea, or by renal loss, including due to use of medications like diuretics or hyperaldosteronism or renal tubular acidosis. It might also occur due to chronic poor dietary intake or even in severe acute malnutrition. It might also occur due to transcellular shift, which occurs due to use of insulin therapy for hyperglycemia or increased carbohydrate load or sudden infusion of high concentration of dextrose containing fluid. Use of beta 2 agonists, which are especially used for respiratory tract diseases like asthma or acute bronchitis, catecholamine surge, metabolic or respiratory alkalosis, and hypokalemic periodic paralysis. There might also be pseudo hypokalemia, which is in vitro cellular uptake in samples with markedly elevated WBC count, and this should always be excluded before treating hypokalemia. Now let's discuss about common cause related to intake and loss. So decreased intake mostly occur in malnutrition, severe acute malnutrition or anorexia. Chronic alcohol users are nutrition deficient in many nutrients, micronutrients as well as electrolytes including potassium. It might also be deficit in prolonged fasting. The common cause of GI loss include vomiting, which causes metabolic alkalosis and renal potassium wasting to correct the alkalosis, and also occurs in diarrhea, which is due to direct potassium loss. And third cause is angiosuction and laxative abuse, in which there is multiple frequent episode of diarrhea leading to potassium loss. Now let's talk about causes of renal loss. Renal loss occurs due to diuretics like loop diuretics or thiazide diuretics. Primary or secondary hyperaldosteronism also causes loss of potassium. Both type 1 and type 2 of renal tubular acidosis cause hypokalemia, and hypomagnesemia impairs renal potassium conservation, leading to loss of potassium in urine and ultimately hypokalemia. The medications other than diuretics which cause hypokalemia include beta 2 agonist, theophylline, insulin, which leads to transcellular shift, non-resolvable anions like penicillins, amphotericin B, and diuretics. Let's talk about clinical features of hypokalemia. Symptoms of hypokalemia may or may not be present, and in early phase, hypokalemia might be asymptomatic, but with increase in severity of hypokalemia and gradual fall of serum potassium level, symptoms may start to appear. The symptoms can be classified as neuromuscular symptoms, which include muscle weakness, cramping, fasciculations, and in severe cases, paralysis might be there. The cardiac symptoms include palpitation, cardiac hyperexcitability, and risk of ventricular arrhythmia, finally leading to arrhythmia. Gastrointestinal causes, gastrointestinal features include constipation and paralytic ileus, and other symptoms include increased frequency of micturition called polyuria, and with severe hypokalemia there might be decrease in ventilation, and there might be decrease in pressure. For severe hypokalemia, which is defined as serum potassium less than 2.5 milliequivalent per liter, there may be life-threatening fatal arrhythmia and respiratory muscle paralysis. So the patient should be admitted to ICU, and hypokalemia should be corrected according to protocol promptly. Now let's talk about ECG changes in hypokalemia. The changes in ECG are typically seen when serum potassium level falls below 3, and they start to worsen progressively with continuous decrease in potassium level. The features of hypokalemia include ST depression, flattening of P wave and T inversion, and presence of U waves. There might be prolongation of QT interval as well. So the difference between hypokalemia and hyperkalemia are just opposite. So flattening of T wave and production of and prominence of U waves is seen in hypokalemia, whereas in hyperkalemia just opposite, widening and flattening of P waves, tall T waves, and QRS widening occurs. As hypokalemia worsens, T waves become progressively small while the U waves become increasingly larger, leading to mimicking a prolonged QT interval. The highest risk of ventricular arrhythmia occurs with progressive decrease in potassium level that includes torsade de pointes and ventricular tachycardia or ventricular fibrillation, especially if there are concurrent structural heart disease or drugs that prolong QT interval. Let's come to diagnostic systematic workup approach for hypokalemia that include confirmation and exclusion of artifact. So if needed, levels should be repeated. Rule out pseudo hypokalemia in markedly elevated WBC counts. History and medication review. So we should start with history. If there is history that suggests the possible risk of hypokalemia, probably due to GI loss, diuretics, laxative, insulin use, beta agonist, poor diet, or alcohol use, we should concurrently check magnesium level, and acid base status should also be confirmed in hypokalemia. Hypomagnesemia impairs renal potassium conservation, so this should also be corrected. And alkalosis or acidosis should also be noted and related with history and examination finding. We should also check urine potassium level and transtubular gradient, distinguishes renal wasting from extrarenal GI loss and transcellular shift. ECD should always be done in all hypokalemia cases to screen for repolarization changes and arrhythmia risk before and while reflecting, and should also be kept in ECG monitor continuously while correcting the hypokalemia. Now let's talk about management principles of hypokalemia. Hypokalemia replacement can either be done orally or by intravenous route. This depends on severity, symptoms, and ECG findings. So the broader approach for mild, moderate, and severe hypokalemia is given here. For milder cases, oral potassium replacement should be done. The underlying cause should be addressed, and rechecking of level in frequent intervals should be done. For moderate hypokalemia, that is potassium level 2.5 to 2.9, oral or IV replacement depending on symptoms should be done. Magnesium should be checked and corrected, and close monitoring should be done. And for severe cases, IV potassium chloride with continuous cardiac monitoring should be done, and it should be checked every 2 to 4 hours until correction is done. The rate of correction is given here. IV infusion should generally be limited to 10 to 20 millimole per hour with cardiac monitoring for higher rates. So it should be slow as possible. Always assess and correct magnesium levels. Replacement is often ineffective otherwise. So if there is hypomagnesemia, kidney will continue losing potassium, leading to hypokalemia, which might occur frequently. And in hypokalemic periodic paralysis, aggressive repression risk rebound hyperkalemia as shift reverses. So the periodic event is over, there might be risk of hyperkalemia, so the correction should be done slowly. So the summary of today's lecture was: the serum potassium less than 3.5 milliequivalent per liter is defined as hypokalemia. Severity is graded as mild, moderate, and severe. The cutoff values are 2.5 and 3. So the key takeaway of today's presentation is: first definition, serum potassium less than 3.5 milliequivalent per liter, and it is classified as mild, moderate, and severe based on cutoff points 2.5, 3, and 3.5. The mechanism of hypokalemia can either be true loss or true deficit, or transcellular shift, which might be transient. Most common causes include GI loss, use of medication, and renal wasting. The most fatal and highest risk of hypokalemia is cardiac arrhythmia, which should be screened by ECG monitoring in moderate to severe cases. And before reflecting, correction of magnesium is mandatory, and identification of underlying cause and treating that cause, and correction of hypomagnesemia as well is important. These are the references. Thank you so much for your time in today's lecture. See you in the next lecture. If you have any feedback, please comment below. If you are new to our channel, please subscribe, and if you are old, please share this video with someone who needs this. Thank you so much.